From the JAMA Network, this is JAMA Oncology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Oncology.
Hello, and welcome to JAMA Oncology Podcast. I am Vivek Subbiah, MD, Medical Oncologist, Chief Early Phase Drug Development at Sarah Cannon Research Institute, Nashville, Tennessee. And I'm also the web editor for JAMA Oncology. Today, it is my pleasure and honor to host Dr. Eileen O'Reilly from the Memorial Sloan Kettering Cancer Center, who is a lead author on the JAMA Oncology paper, Lynch syndrome and somatic mismatch repair variants in pancreas cancer. Dr. Eileen O'Reilly, please can you introduce yourself?
Thanks so much, Dr. Subbiah, and thank you very much for the invitation to be here today. I'm a medical oncologist at Memorial Sloan Kettering Cancer Center in New York. I lead our clinical and translational research program in pancreas cancer, and delighted to be here to discuss this with you.
Fantastic. Thank you so much. So briefly to our viewers here, the study investigates the clinical genomic features and treatment outcomes of Lynch syndrome and somatic mismatch repair variants in pancreatic cancer, highlighting that MSI high status is a predictive biomarker for response to immune checkpoint blockade therapy. Please give us an overview of your study and major findings from your study.
Great. Thanks again. So delighted to present this. And I just want to acknowledge that this work was led by Catherine O'Connor, who's a graduate student who's in medical school with a collaborative team. And so I have the privilege here of summarizing these data for you all. So the backdrop to this is that pancreas cancer is a disease which is increasing in incidence. We know that about 1, maybe 1.5% of people will have mismatch repair deficiency. There is discordancy in the literature as to whether mismatch repair deficiency in pancreas cancer is driven by germline events, driven by somatic events, driven by both, and also discordancy with regard to the value of immune checkpoint blockade therapy. So, for example, some of the older, in relative terms, literature suggests that people with mismatch repair deficient pancreas cancer may not respond very well to immune checkpoint blockade. And that wasn't resonating with our clinical experience. So that led us to take a really deep and focused genomic and clinical and translational look at this patient population to understand what the frequency of mismatch repair deficiency in pancreas cancer is, whether there were somatic events that were driving it in addition to known Lynch syndrome, and to better understand the response to immune checkpoint blockade, and to provide insights on how we should test for mismatch repair deficiency in pancreas cancer. And the overall summary points, the take-home message here is about 1% of people, about half of mismatch repair deficient pancreas cancer comes from a somatic event. And that when we do identify either germline or somatic mismatch repair deficient pancreas cancer, about half the tumors are related to biallelic loss. And we see substantial benefit to immune checkpoint blockade in this disease. We also see that there are some discrepancies with traditional methods of testing for mismatch repair deficiency, and that there are some newer tools that we want to introduce to the audience today that may help address some of the challenges of tissue testing in pancreas cancer.
Oh, thank you so much for that broad overview. And all the more it becomes really important study led by a graduate medical student. Wow, what a bright future and what great mentors she has early in her career. One question to you, Eileen, is how did you determine the optimal combination of orthogonal testing methodologies for identifying MSI high status in pancreatic cancer? And what challenges did you encounter in the process?
Yeah, thanks, Vivek. So this is a great question, a really practical one on the day-to-day of how should we approach testing in pancreas cancer. So Tissue is a luxury in this disease, and we need it more and more to identify these rare genetic events for which there are actionable implications in terms of treatment options that can impact outcome. And this is a prime example of one of those. So, traditional testing uses mismatch protein expression loss to determine deficient mismatch repair. And in pancreas cancer, if we do that, often that limits our ability to do other things. So increasingly, we want next generation sequencing information to also know whether this individual has a KRAS mutation or other actionable findings in their tumor. So doing next generation sequencing, you can obtain that latter information, but you can also, using AI tools, determine mismatch repair deficiency status. So you get 2 for 1 and 3 for 1 often in that setting. And some of these newer tools address some of the challenges of low cellularity or necrotic tissue, or the fact in mismatch repair deficient tumors, you have a ton of lymphocytes present, you have a low epithelial component, and you're working with a very small amount of genomic material to determine whether or not MSI high is present. So these are some of the kind of key issues, and these tools can allow, with pretty high prediction, identify who's mismatch repair deficient.
Oh, thank you so much. You mentioned about AI and AI classifiers. So given that AI classifiers reclassified approximately 20% of cases as MSI high, how do you envision the integration of these AI classifiers into routine clinical practice, particularly in settings with limited resources?
Yeah, so some of these tools are already being used today. And for example, one of them is MSI sensor, and this looks for replication alterations at microsatellites, and you can differentiate between somatic and germline. And this data now goes back, almost a decade. And so this has CLIA approval. It's integrated, for example, in our MSK Impact platform. So we obtain this information when we request next generation sequencing. But there's several generations on, and one of these new tools is called My MSI, and this has a greater prediction for addressing issues related to cellularity, necrosis, and some of the challenges that we encounter, in particular across solid tumors, but across pancreas cancer and other malignancies. So it's a multiple instance learning model that uses a prediction algorithm to identify these patients, and it even surpasses what the prior generation had yielded. So it's high sensitivity and it's very specific, and it can address low cellularity, low tissue purity, and even with low sequencing coverage. So all of the challenges that are inherent often in pancreas cancer. It is a next generation sequencing tool, and it does take time, and no question that it requires expert bioinformatics and statistical expertise and interpretation. So these are some of the downsides. But trying to rationalize all of this, just identifying this patient, right? When you focus it back to the individual, if we're limiting an opportunity for a person with pancreas cancer to receive immune checkpoint blockade, I think that's a huge worry and concern. If we overtreat, maybe that's different, but I think if we don't recognize this possibility and have that option available, that's a miss in this disease, in any disease.
So your findings indicate variant-specific differences in MSI high potential, especially among Lynch syndrome-associated pancreatic cancers. Could you please elaborate on the clinical implications of these differences, especially regarding personalized treatment strategies?
Yeah, thanks so much, Vivek, for this question. And recapping on a Lynch syndrome driven pancreas cancer, the main genes that we see are MLH1, MSH2, MSH6, and PMS2, and then very occasionally EpCAM1. These are germline events. They are associated with elevated tumor mutation burden, elevated MSI sensor score being a measure of mismatch repair deficiency, and certain genes are more likely to have a higher TMB, a higher MSI score, and potentially higher benefit from immune checkpoint blockade. And in pancreas cancer, the key genes that we saw in this regard are MSH2 and MLH1, and they occurred in younger patients, so presumably a higher phenotypic manifestation of Lynch syndrome. So those genes in particular are really key. But we also saw that while PMS2 may occur in older patients with mismatch repair deficient pancreas cancer, we saw some striking durability in the setting of mismatch repair deficient PMS2 driven pancreas cancer as well. So it's not straightforward. And again, key thing is to sort of identify these genes and identify the correct mismatch repair state.
Well, thank you so much for that detailed explanation. So the study reports a significant benefit from immune checkpoint blockade in patients with pancreas cancer and MSI high. Could you also elaborate and discuss on any observed factors or biomarkers that might predict which patients are most likely to benefit from immune checkpoint blockade therapy?
So the first main data set was about 5, 6, 7 years ago now, which showed a response rate of about 18%, a short PFS and short OS. And that again was not felt to be truly reflective of mismatch repair deficient pancreas cancer and immune checkpoint blockade impact. More recent data sets from the Mayo Clinic, from colleagues in Europe, have suggested response rates can be significant, complete responses can be seen, and these responses can be very durable. There is a suggestion that certain genes, we've talked about MLH1 and MSH2, perhaps contributing more to the impact of immune checkpoint blockade. I think one of the other things at a genomic level is whether the second allele is lost, and this applies both to germline-driven mismatch repair deficiency or somatic events. So biallelic loss may influence the outcome. We believe that responses are higher in those who have a biallelic state, but it wasn't exclusive in either direction. So that was interesting. We also, found that about half of people who had pancreas cancer who had a mutation in a Lynch gene, germline or somatic event, that these tumors, about half were microsatellite stable. And that's important too, because that group is unlikely to benefit from immune checkpoint blockade and probably shouldn't receive those agents. I think one always wants to err on the side of doubt, but when all the parameters point to microsatellite stability, be it via IHC or be it via MSI sensor tool or MyMSI or other classifiers, you can be pretty confident of all of those orthogonal methods of testing are concordant as microsatellite stable, then it's unlikely in that context that immune checkpoint blockade would be beneficial.
So, based on your findings, what are the next steps in research to further understand the mechanisms driving MSI high in pancreas cancer? And how do you plan to address the limitations mentioned, such as the single center nature of the study, the retrospective nature of the study? What are the next steps?
Yeah, next steps for us are to hopefully see that this additional classifier can become part of routine practice, and our colleagues who've worked closely on developing this are hopefully going to see this in print relatively soon. It's referenced in bioRxiv now, so I think that will be a step to wider availability of this and potential incorporation of this. From the research side, we have lots of interest in a deeper look. We did some exploratory evaluation of mutational signatures to see if we're seeing mismatch repair deficient signatures. Having said that, we had a lot of limitations in that this analysis was done on next generation sequencing and not, for the most part, on whole genome sequencing. So we would be interested in further evaluating that and understanding if that leads to new insights. Of course, understanding what the mechanisms of resistance are, how we might address that in practice. And we have our eyes open from all that's going on in other fields. And to see if we can reclassify some of these variants of unknown significance that have suggested that they are oncogenic by virtue of the clinical impact and the next generation sequencing findings, but don't have the preclinical support to be reclassified. So that's some of the research directions that we're interested in this space. And we're also interested in expanding this analysis to other genes that are associated with genetic predisposition to pancreas cancer and understanding their connection with this disease.
Thank you so much, and congratulations on the paper Lynch syndrome and somatic mismatch repair variants in pancreas cancer, and also for sharing your insights on this podcast.
Thank you so much, Vivek, and thanks to the wonderful team that we have the privilege to work here with at MSK who helped with all the work.
Thank you. I'm Vivek Subbiah, and I've been speaking with Dr. Eileen O'Reilly from the Memorial Sloan Kettering Cancer Center about Lynch syndrome and somatic mismatch repair variants in pancreas cancer. We aimed to dive deeper into the methodologies, clinical applications, variant-specific observations, treatment implications, and future research directions highlighted in the paper. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Musisi at the JAMA Network. Thanks for listening.